Hello, I'm Dr. K. working as a reader in the Department of Oral Pathology, Pushpiri College of Dental Science, Tiruvalla. And I'll be explaining about Pemphigus vulgaris as a part of e-learning from my department. So the objective of my today's class would be the first one, classification of vesiculobullous lesion. Then I'll be talking all about Pemphigus vulgaris. So before moving to the classification of vesiculobullous lesion, I would like to brush up regarding what is vesicles and what is bullae. A superficial blister with clear fluid which is equal or less than 5 millimeter is known as vesicles, which is seen in this picture. And if it is more than 5 millimeter, we call it as bullae. This is the bullae. So clinical manifestation, we can see how will be the vesicle less than 5 millimeter and more than that is bullae. So the classification of vesiculobullous lesions goes like this: hereditary conditions where you have epidermolysis bullosa and dyskeratosis congenita are examples. And also we can have vesiculobullous lesion along with infections, where in viral we can have herpes simplex infections, varicella zoster, herpangina, hand, foot, mouth diseases. And under bacterial infection we can have impetigo. In miscellaneous we can have allergic contact stomatitis as well as erythema multiforme. And under immunological we can have Pemphigus vulgaris or any pemphigus lesions, pemphigoid, linear IgA diseases as well as bullous lichen planus. So whatever I've given that yellow color, all are dermatological disorder there, which are mucocutaneous. So regarding the types of pemphigus, the term pemphigus came from Greek word pemphix, which means bubble or blister. So there are different types of pemphigus: Pemphigus vulgaris, Pemphigus vegetans, Pemphigus foliaceus, Pemphigus erythematus, Pemphigus paraneoplastic pemphigus, which is seen along with the neoplasm malignancies, associated malignancies, drug-related pemphigus. So here today's topic would be the Pemphigus vulgaris, which is the commonest of all the pemphigus lesions. The vulgaris means common. So this is the most common pemphigus is Pemphigus vulgaris. So Pemphigus vulgaris, which is an autoimmune mucocutaneous blistering disease, as we see in these pictures. This is caused by, it is caused by autoantibodies. I said it is an autoimmune disorder, definitely there has to be autoantibodies. So autoantibodies are produced in our body against desmoglein 1 and 3 in the keratinocyte cell junction or desmosome, which causes acantholysis, that is separation of the cells, and which leads to blister formation. This particular name was given by Wichmann in 1791. So we can see there will be vesicle formations. These vesicle formations are joined together to form, they will rupture and form, and they join together to form a bigger ulcer, smaller ulcer, then later into a bigger ulcer. And also you can appreciate in the lip. Regarding the etiological factors of this particular Pemphigus vulgaris, there are some etiological or predisposing factors like drugs, phenols, diclofenac sodium, or anti-hypertensive, that is captopril. Also, we have something association with diet, that is garlic, the common, in our diet, garlic, radiation, also stress, and also surgery, associated surgeries, associated pregnancies. And also there are some viral infection, HHV8 viral infection, or pesticide, in contact with the pesticide, or with systemic lupus erythematosus, again another autoimmune disorder, or rheumatic arthritis. So there are some predisposing factors for this particular autoimmune disorder. So regarding the pathogenesis of Pemphigus vulgaris, there are different theories have been proposed, like desmoglein compensation theory, multiple heat hypothesis, antibody-induced apoptosis theory, basal cell shrinkage theory, and apoptolytic theories. But all in one word, we say that, or the most accepted one is autoimmune disorder, the pathogenesis, where the autoantibodies are produced against desmoglein 1 and desmoglein 3, which are, you can see this where I put the star, that is desmoglein. This is one keratinocyte or epithelial cell, another epithelial cell. These cells are united, that is desmosome. This desmosome has got extracellular component and intracellular component. This desmoglein is in the extracellular component. So these desmogleins are affected by the autoantibodies. So the Pemphigus vulgaris is caused by the autoantibodies specifically produced against desmoglein 3. Desmoglein 1, then we call it as Pemphigus foliaceus, that is mainly seen with the skin. So this is the basic pathogenesis of the Pemphigus vulgaris, that is autoantibodies produced against desmoglein 3 for Pemphigus vulgaris. So as I said, it is an autoimmune. There will be damage is directly proportional to the amount of antibodies. So the autoantibodies quantity definitely will give the clinical manifestation. The circulating antibodies of type IgG activate inflammatory mediators and recruit T cell, which releases the proteolytic enzyme against desmosomes or tonofilament complex, which leads to acantholysis. That is separation or detachment of epithelial cells. So regarding the epidemiology of Pemphigus vulgaris, the incidence rate is 0.5 to 3.2 in 1 lakh population, where the male-female ratio is 1.2 or 1.1. Age, commonly it is seen with elder population, that is 50 to 60 years. But in India, we can have more younger population are affected. And regarding some racial predilection, that is Ashkenazi Jews and people in Mediterranean origin, they are more prone for Pemphigus vulgaris. Around 80 to 90% of patients develop oral lesions and 60% develop oral lesions as first symptom. As it is a mucocutaneous disorder, the skin is affected, oral cavity is affected, but many of the patients are presented with oral lesions first. Occasionally associated with some autoimmune disorders, and also herpes simplex infection or some internal malignancies. So internal malignancies, we normally call it as paraneoplastic pemphigus. So regarding the clinical feature, there will be a sudden appearance of vesicles or bullae on the skin or in the mucous membrane, which ruptures soon to form ulcer. So as this is happening because of acantholysis, which is happening inside the epithelium, this vesicle and bullae will be very thin, and normally it ruptures very fast, especially in oral cavity, as come across with a lot of food intake and trauma. So that very easily it ruptures to form ulcer. So normally we need to during the clinical picture or examine the patient, we won't be able to find any vesicles, but it is very important to ask for a proper case history, asking them whether they had any vesicle previously. So they'll be telling, some will be telling they were having and it got ruptured, and some are not even aware of vesicle formations. So there will be watery fluid in the vesicle, or sometimes may become purulent. These ulcers, I already said, they will rupture to form ulcers, small ulcers. All these ulcers will join together to form a big ulcer, which is very painful for the patient. And the common site we come across in the oral cavity, skin, esophagus, cervix, nose, pharynx, and larynx. So skin as well as mucous membrane, any part of the mucous membrane. So regarding the oral manifestations, I already said some of the patients or most of the patients, the first clinical presentation will be oral lesions. So the symptom of the patient will be, they'll be coming to us complaining, their complaint will be painful ulcers or intolerance to spicy food. It will be very painful, And they may not be telling about vesicle as a complaint. So this particular lesions, oral lesions, which are first to show, last to go. There will be sudden appearance of vesicles of bullae on non-inflamed base. There won't be any inflammation on the base. Let it be in the skin or oral cavity, there won't be any inflammation. Just you will have a vesicle or bullae formation, which can be commonly seen in oral cavity, buccal mucosa, palate, and gingiva. These vesicles of bullae will rupture fast within hours, and patient, I already said the patient may not be aware of the vesicles. Shallow, painful, irregular ulcers, which will be very slow in healing. This healing process is very slow here. And the edges continue to extend peripherally. It is like you have an ulcer. This ulcer is extending. So you can appreciate that extending if you have follow-up. And there will be desquamative gingivitis. Patient normally, some of the patient complaint will be desquamation of gingiva or peeling of gingiva. So when you see, the signs with the clinical signs will be a desquamative gingivitis or whole gingiva is red in color and the epithelium is peeled off. So we can appreciate all those things in this oral cavity. This is the buccal mucosa lesion, the lip lesion, as well as we can see palatal lesions. So nikolsky sign. So this nikolsky sign is something a clinical test we'll be doing to confirm Pemphigus vulgaris. So it's a clinical dermatological sign on rubbing apparently unaffected skin, which strips of what you see in this, how you see on this, you can see the stripping of the epithelium or the skin, or extension of bullae on pressure. If you put pressure on a bullae, the bullae will extend. So this is a positive characteristic of Pemphigus vulgaris. The upper dermis separates from basal layer due to pre-vesicular edema. So whatever is happening, acantholysis or the detachment of the keratinocytes, so the base membrane is intact, the upper area will be peeling off. So differentiate intraepidermal from subepidermal bullae. If the nikolsky sign is positive, which shows that this is something, the problem is happening intraepidermal, not subepidermal. This is also seen, what you have seen, this nikolsky sign, it is not something specific to this particular Pemphigus vulgaris. You can see that in familial benign chronic pemphigus as well as epidermolysis bullosa, which is an hereditary or a genodermatome. So you have two types of nikolsky signs, that is marginal as well as direct. In marginal, on rubbing surrounding, if you rub the surrounding area of the erosion, again there will be extension. And in direct, what you see is no erosion on rubbing normal appearing area. So in marginal, on rubbing, the surrounding of will be, the surrounding area we have show erosion or extension. And in direct, what happens is no erosion on rubbing normal appearing area. So there is something called indirect nikolsky sign, that is also known as Asbo-Hansen sign or indirect nikolsky sign, where the extension, as you see in the picture, See, there is a vesicle formation or a bulle formation. You have given a marking there. And if you put pressure over this bulle, what happens is you can see the extension of bulle over that marking. So we can see that the pressure causes extension of the bulle, which is known as indirect nikolsky sign. We also have something called nikolsky phenomena. That is when superficial layer of epidermis is felt to move over the deeper layer, new bulle develops within 24 hours. That is, if you try to wrap the area or try to move the area surrounding the lesions or the normal areas, you can see that within 24 hours there will be new bulle formation. That is known as nikolsky phenomena. There is something called Pemphigus vegetans, which is very uncommon variant of Pemphigus vulgaris. Normally we have only 1 to 2% of this will be appearing. It's seen with 40 to 50 years, where you can have hyperpigmented vegetative plaque with pustule. You can see in the picture. Also, you can appreciate the oral cavity lesions. So there will be a plaque with pustules. And also something called cerebriform tongue. If you appreciate this tongue, this on a cerebriform tongue means this will have a appearance of cerebrum. That's why cerebriform, sulci and gyri on dorsum of the tongue. Even deletions also called as skin lesions, also having the same type of appearance, also called as cerebriform skin or skin lesions. Regarding the histopathology, the biopsy site is very important. Normally, the clinician or the oral surgeons will be requesting oral pathologists to come and give the site for the biopsy, incisional biopsy to be done. So normally the biopsy site is, choosing the biopsy site is very important, because if you choose only the lesional area like other lesions, what happens is here the epithelium, the presence of epithelium is mandatory to give a diagnosis. Without epithelium, we cannot give any diagnosis, because this is happening intraepithelial acantholysis. So we need to have a biopsy site where 50% should be from the lesion and 50% we have to take from the normal appearing areas. Then only that will be a genuine biopsy specimen for the histopathology investigation. So histopathologically, what you see is acantholysis. You can see acantholysis, formation of bulle over the basal layer, suprabasilar split, subbasal remain attached to the basal lamina, and presence of TZANCK cells. See, as you've seen in this histopathological photomicrograph, we can see very clearly that there will be acantholysis and the presence of TZANCK cells. These are the TZANCK cells, which are free epithelial cells. And also you can have this tombstone. There is basal cells remain attached to the basal lamina, which is giving a tombstone appearance. This is a tombstone appearance. You can see basal cells. And also you can see sponges. Sponges is nothing but the epithelial cells are, filled with water, absorb water, and there will be more. This size will be increased. So that is, so histopathology features, the main feature is you can see acantholysis, and you can see a suprabasilar split with a lot of TZANCK cells, and you can see the tombstone appearance of the basal cells. So in this picture, it is more clearly shown that these are the TZANCK cells. They are detached epithelial cells, and very clearly we can see the tombstone basal cells. So these TZANCK cells are small rounded cell, contain hyperchromatic nuclei. There is something called TZANCK test. This TZANCK test is a simple diagnosis cytological method for mucocutaneous blister lesion. That is from TZANCK smear. TZANCK smear means we will be opening up a new vesicle. From that, we are collecting the smear and we are making a smear over the glass slide. Then we'll be staining with Giemsa, methylene blue or papanicula or even toluidine blue. Then we'll see under the microscope. We'll be the cells are appreciated in this way. There will be multinucleated giant cells formed by the fusion of acantholytic keratinocytes. So you can appreciate this. These are the TZANCK smear. And this is seen in Pemphigus vulgaris, and also this TZANCK test can be applied, or TZANCK smear can be seen with chickenpox, herpes simplex, as well as herpes zoster. So here the special stains are used is Giemsa, methylene blue, even papanicula, as well as toluidine blue. So this smear is known as TZANCK smear, and this test is known as TZANCK test. So you can appreciate more of the TZANCK cells here with different stains. And actually, there are some cytodiagnosis with TZANCK smear. In Pemphigus, the cells will be more TZANCK cells, there will be morning edge cells, and the different cytodiagnosis for Pemphigus vulgaris, bullous pemphigoid, or other herpes lesions. So this is regarding that. There will be some difference in the smear. Immunofluorescence test. This particular test is mandatory if the biopsy specimen is not revealing whatever we tried many times, still the epithelium is not getting. So the immunofluorescence test is a confirmatory test to be done for Pemphigus vulgaris. So this is a technique allowing visualization of specific protein or antigen by finding specific antibody chemically conjugated with fluorescent dye. So this specific antibody is labeled with fluorescent isothiocyanate, FITC, so which gives an apple green color under polarized light. So we have two types of immunofluorescence test. One is direct immunofluorescence and there is indirect. In direct immunofluorescence, the sample will be the specimen, the tissue, the biopsy specimen or the tissue, which has to be collected in Michael solution for fixation. And this is the tissue where the tissue will be, there will be treatment with labeled antibody. The antibodies are labeled. And after that, we'll unbound antibody washed away. Later, under UV light, if you see, if the antigen is present, definitely they will conjugate with this, and we can see an apple green color under polarized light, under fluorescent microscope. And if it is not seen, you don't find any kind of apple green color under fluorescent microscopy. In the indirect immunofluorescence, where the sample is taken patient serum. So the serum, the serum is applied here. Then and again the antibodies are the serums. The antigen is here. The serum is applied over here, and there will be washing. Then after that, we are doing. There will be secondary reaction with the conjugated or fluorescent conjugated antibodies, which will give fluorescent color. And if we, under microscopic examination, if unlabeled antibodies are there, then you won't get any fluorescent color under fluorescent microscopy. If we have a labeled antibody, then definitely there will be fluorescent color. Means here the antigen is present here, but here the antibodies, the patient serum is used. So it will give a characteristic chicken wire appearance. As seen here, a chicken wire fluorescent color, apple green color we can see here. And this is by direct immunofluorescent test, and this is by indirect immunofluorescent. The direct immunofluorescent test is the best test to confirm Pemphigus vulgaris. Indirect is commonly used to assess the severity of the lesions and even the follow-up. So regarding the diagnosis of Pemphigus vulgaris, there are different ways we can confirm it. That is by clinical examination necrosis phenomena, TZANCK smear, biopsy, compressed air test. That is done, you are applying a stream of compressed air on the gingiva, there will be blister formation, and immunofluorescent, that will be direct or indirect, and ELISA. Differential diagnosis will give us bullous pemphigoid, cicatricial pemphigoid, paraneoplastic pemphigus, erythema multiforme, aphthous ulcer, and erosive bullous lichen planus, as well as herpes simplex. So in bullous pemphigoid, definitely histopathologically that is not intra-epithelial the cleft. Here there will be subepithelial cleft will be there. And in cicatricial pemphigoid, in bullous is commonly not associated. Both the pemphigoid you will have subepithelial cleft. Bullous is not commonly seen with oral cavity. Cicatricial means there will be a scar formation after the lesion heals. In paraneoplastic, that is associated with the malignancies. Erythema multiforme is a bullseye lesion where you have bullseye appearance lesion over all the skin. After stomatitis, we know that there won't be any vesicle formation before ulcer formation. And erosive and bullous lichen planus, again, they are the bullous type of lichen planus. Here you can see in lichen planus is characteristically symmetrical striation, which is absent in Pemphigus vulgaris, and herpes simplex, which is a viral lesion, which is mainly seen with children, and there will be prodromal symptoms like fever, which is absent in Pemphigus vulgaris. So regarding the management of Pemphigus vulgaris, there are three phases, that is control, consolidation, as well as maintenance. So when it is diagnosed, first thing what to be done is to control the lesions. So any autoimmune disorder is concerned, the first line of treatment would be the steroid application. According to the status of the lesion, we'll be giving topical or intraoral or sometimes intralesion injections or IV fluid. So topically, we give high potency corticosteroid ointments, or with the solution after 10 years, a study is revealed. And remission as well as exacerbation also seen with the patient. It comes, sometimes it goes like that. And the mortality rate will be 5 to 10%. That is, the mortality rate is because of the steroid. If you are under steroid for a long time, you can come across with the complication of steroids. So there are, out of 100 patients, 5 to 10 patients are dying. Thank you.